You're listening to Parents You've Got This, the expert guide to parenthood, the complete guide to fertility, pregnancy, birth, baby and parenthood. This podcast is proudly supported by Mistela, a natural origin skincare for babies and children, recommended by healthcare professionals. Mistela by Parents' Side since 1950.
This week on the Expert Guide to Parenthood podcast, we are talking all about red flags in pregnancy. Now, the most important thing here is that if you are feeling unsure about things, that you seek the advice of your healthcare practitioner. The red flags we're going to be talking about today are some of the more common things that you may experience and why it's important that you go and get help.
We have our obstetrician expert, Dr. Peter Jurcevic, back in the chair. Dr. Peter is an obstetrician and gynaecologist with more than 28 years of obstetric and gynecological expertise. He specialises in high-risk pregnancies and he's also one of the Australian pioneers of the maternally assisted caesarean. Thanks so much, Peter, for joining us to talk about red flags in pregnancy. Pregnancy is such an exciting time, but it can also be a really worrying time for the pregnant mama and the dads-to-be. Can you talk to us a little bit about what some of those red flags are, starting perhaps with abdominal pain?
Sure. Well, it's a pleasure to talk on the topic. Abdominal pain, you probably first begin by thinking what stage of the pregnancy are you in. Are you in the first trimester, the second trimester, the third trimester, so the first 13, second 13, last 13 weeks of the pregnancy. And then you'd be sort of factoring in other things in relation to the person, whether it's her first pregnancy, her age, other mitigating past health history and so on. And then the question, of course, will be, you have pain, and so you'd be wanting to get a sense of where the pain is, so high or low in the abdomen, localised to the centre, to the sides, going through to the back, down the legs, etc. The brevity of the pain, the nature of it, sharp, dull, etc. And so as part of just good medical care, we would ask you a standard series of questions specifically for that. And then we're always interested in other associated symptoms. So, for example, were you bleeding, vaginally? Do you have urinary symptoms? Is there any bowel symptomatology? Do you have a fever? Have you had a recent illness? Something you might have eaten? Anyone else around you not well? And if it's at that right stage in the pregnancy, we can ask the question, do you feel baby movements? You'd be also thinking about what testing you've had so far, what scans you've had, and so on. And then that would allow you to, a little synopsis of what you might be thinking as causes. As a general rule, and this is a generalisation, but I know that in early pregnancy, if you have pain, I'd be thinking, is there a chance of miscarriage? Is there a chance of an ectopic pregnancy? Okay, they would be the baby-specific issues I'd be concerned about. In the latter stage of the pregnancy, say the midpoint onwards, I'd be thinking about, is there a chance that you could be having a cervix that's opening unexpectedly? Is there a chance you are in premature labour? Is there a chance that you have had a bleed within the cavity of the uterus, what we call an abruption? Or is there a chance that you might have, waters are broken and you have an infection in the uterus? And in general terms, with some other exceptions, but in general, they are the things that I would be thinking of based on the time of the pregnancy. They're baby-specific. Baby-specific causes of pain that would be potentially detrimental to the outcome for the baby. But in your abdomen, there's a lot of other things. There's your bladder, there's your bowel, there's a spleen, there's a kidney, gallbladder, pancreas, stomach, kidney tubes coming down, the ureters, ovaries. So I will often ask a series of questions, and this would be particularly relevant if I was having a phone conversation with a patient, as distinct from a face-to-face where I can then examine and scan them. And doing a series of questions which in some respects is trying to hone in on what I think the cause is and also try to exclude the things I don't think it will be. Okay? And really the key is, do I have a sense that the baby's at risk, or do I have a sense that you, the woman's, at risk? And if that's the case, then that would always then involve an examination, because that's an important part of your care, and invariably some form of investigations, which obviously and conveniently, when you can, a scan is very useful because you can eyes on the baby straight away. And then other testing where it might be a urinary screen or blood tests for infection or etc. So a lot of the time in pregnancy, you are growing a baby in your uterus. Your uterus will be smaller often than the size of my fist when you're not pregnant. But by the end of the pregnancy, it's filled up your entire abdomen with on average 3.5 kilos of baby. Now, not surprisingly, the muscle and the ligament attachments are all stretched. And so you'd be pleased to know that for the vast majority of women, if you have abdominal pain as a loose term, musculoskeletal stretching will be the cause of that pain, the vast majority. But again, those things we think of, miscarriage, bleeding, premature labour, other things outside the uterus, appendicitis, etc., we would be thinking about all of those things, and it would be a diagnosis of exclusion that ultimately will hopefully get us to the most common cause of your pain, which is going to be stretching.
What about vaginal bleeding, Pete, in pregnancy? When is it a worry?
Sure. I think the best way to answer the question is vaginal bleeding in pregnancy is never normal, but it doesn't necessarily mean it's going to lead to an abnormal outcome. So it's important to state that. So whenever you have bleeding in pregnancy at any stage in the pregnancy, it's probably sensible advice to seek, advice to seek an examination, and ideally to seek a scan, because that's going to really just have a look and see what's going on with the baby, the placenta, the sac, the cervix. And that would be at any gestation, recognising, of course, that we can't see much on a scan under 6 weeks in the pregnancy, but certainly from that point onwards all the way to the end. So when you have bleeding, and particularly in the first trimester, so the first 13 weeks, it can just be discharged from the outer cells of the cervix, what we call cervical congestion. The cells are very brittle cells, they're very thin cells. The cervix itself constitutionally can be a very thick, strong, robust organ, and the baby inside above that in the sac is well encapsulated and safe, but those surface cells, lots of blood going to the pregnancy, it's nourishing the baby, it's growing a baby, but all that blood going to the cervix, those cells can, in loose terms, pop under pressure. Now you won't know that, and I won't know that without examining you, but that can often be the case, and there'll be no risk to the baby whatsoever. But we can sometimes have situations where the sac is filling up all the little nooks and crannies of the uterus, and we get a bit of what we call implantation bleeding. Or occasionally when a little blood vessel's going into the placenta, into the sac, kind of just bursts, so to speak, and you get a little clot develop. Now, in most of these situations, if the pregnancy is seen and viable and healthy at the time, the cervix is closed, it's measuring well for dates, heartbeats going along, there'd be confidence the pregnancy will remain okay, all right? But that's as a sort of just a loose comment. It's time and or follow-up scans on all the brevity of the situation that will dictate that. So I would always say heavy bleeding is never as good as light bleeding, and painful bleeding is never as good as painless bleeding. And obviously the time and the stage of the pregnancy. But you can disappointingly, dare I say, have just a little tiny little nibbin of blood that could just be brown discharge with no pain whatsoever at 8 weeks, and you could come in and have an assessment and disappointingly be found to have a pregnancy that's no longer viable and maybe an early miscarriage, etc. So bleeding is one of those ones where, and later in the pregnancy included if you've got an O-line placenta, or if you're 33 weeks pregnant and there's a chance you've got some associated discomfort, you could be labouring, is probably one of those ones where you should always seek advice. Generally that advice will usually lead to an examination, but again it just depends on your understanding, particularly as a doctor, of your patient, where they are in the stage pregnancy, where they just had a scan the other day, etc., etc.
Another red flag can sometimes be reduction in baby's movements, but how do you know? It's such a varied thing, baby's movements, from person to person and baby to baby. How do you know when something like that is some time to call your obstetrician or your care provider?
Sure. I think the easiest way to answer that question is, when in doubt, just call. Call your obstetrician, call your midwife, call the hospital you're being delivered at, and invariably there'll be an offering of some form of fetal heart check, whether it be just an assessment of there's the heartbeat, through to a CTG, which is a type of heart monitor we can do at an appropriate gestation in the pregnancy, and even an ultrasound scan when we need to. It's really interesting, and I'd be happy to be very honest about this, is that, with almost 30 years of working in the business, fetal movements is still one of those conversations with patients where I can't always give an absolute black or white answer. I can give you a black or white answer, come into hospital and have a monitor, but the interpretation of movements and what is or isn't reduced and when is it's a worry, it's so much variance. The first movements will often be no earlier than on average 16 weeks, but a woman with an anterior placenta may not feel movements until 22 weeks, a big cushion in the way. Some women have a naturally low perception of movements. It's really interesting when you scan a woman who's presented with reduced movements and you've got the scan on her belly, the scan probe is moving off the abdomen, because the baby's kicking that hard. You can see the baby's rhythmic movements through her skin. The baby's kicking like crazy on the scan, and you point this out to the woman. She says, I'm not feeling it. Okay. Now, that's extremely reassuring for me, but it's still an ongoing issue for the woman, because if she can't feel the baby moving, she can't ascertain if the baby is or isn't well. Out of interest, again as a general stat, but well over 98% of women, when they present with reduced fetal movements at whatever gestation, the baby's actually constitutionally well. Okay, so it would only be a very small percentage of babies that would be unwell. Unfortunately, it's those 2% that keep us on our toes for the whole 100%. Okay, and when a baby is not moving much, in general terms, what we're concerned about is, God forbid the baby has succumbed already, but more importantly is the baby's conserving. It's not moving because it's conserving. And why would a baby conserve? It would conserve if the placenta is not functioning properly, i.e. not enough food, not enough nutrition to the baby, and God forbid not enough oxygen. Okay, so I'm always thinking when a woman calls and or presents, what are her pre-existing risk factors, issues, etc.? Why would this woman who I might have seen 2 days ago, who was in perfectly good health, measuring perfectly, had a scan recently, the baby was biophysically perfectly well, why would this baby all of a sudden be hypoxically at risk? Now, I know in my heart of hearts that's extraordinarily unlikely. So I have confidence that I know when she comes in the baby will be well. But without that monitor, I don't know for sure. So really, in general terms, if you can't get used to your baby's rhythm, your circadian rhythm of movements, remember babies don't have a sunroof. Their interpretation of day and night, even when they're born, is very different to what we would like as an adult. So if your baby's out of sync with your usual movements, you've done your usual poke or prod, you've had something cold, something sweet to eat, you've done all the things you can try to stimulate your baby, it remains quiet, and that's your definition of quiet, not my definition, not someone else's, then you just come and get a check. And you'll be pleased to know well over 98% of the time that check will be normal.
What about if you felt a difference or a change in your own personal wellbeing, Pete, and you just have this feeling? Can that be a red flag too?
I think in fairness, you can have no red flags and have problems, but equally, yes, if you have concerns like that, yes, it could be a red flag. I guess the really tricky situation is from that very moment when that little egg and sperm meet and there's a fertilised conception that now grows in your belly and hormones and everything, there's a lot going on in your body. Your cardiac output's up, your metabolism's up, your respiratory system, respiratory compromise when you sort of tent your diaphragm as the baby's pressing up and you get short of breath. Things will ache. You'll get fluid retention. 95% of people get fluid retention. 97% of people get preeclampsia. Swelling from preeclampsia is a thing, but the majority of you are getting it because it's just physiology. Movement patterns that are up and down. You've had a really busy day at work. If you're working and you didn't pay attention to the movements, the baby may well have been moving, but you weren't paying attention. Was my baby moving? You're just having this sense of something's not right. I feel sick all of a sudden. I've got a headache all of a sudden. My vision's a bit blurry all of a sudden. All these things are very often the really challenging physiology that you, the incubator, put yourself through to nurture a growing baby. And the good news is the vast majority of the time they are just normal, annoying features of the process. But when you're not sure, the easiest thing to do is get a check. Get your vital signs, your blood pressure, heart rate, etc. checked, check the baby's heartbeat and give you that peace of mind. And if I use a very, very polite but considered comment, the worried well, I see a lot of worried well, okay? Yeah. But they're great appointments because I know that everyone's going to be okay. I know the mum will be well. I know the baby will be well. And if that 15-minute interaction takes away another 24 hours of anxiety, that's a good interaction. Even though I know that there was probably nothing medically wrong with the person. Every now and again, you will walk in with a sense of dread and there'll be an issue. And you'll be forever grateful you came in for that checkup.
Absolutely. And so, Pete, one of the other signs that a red flag in pregnancy can be waters breaking with like blood stain or meconium. Can you talk about why that is a worry?
Sure. So we will assume that the vast majority of women, if they are going to progress all the way through to the end of a 40-week pregnancy, the vast majority will make it to the 37th week of that pregnancy, so what we would call term by definition. And there'll be a percentage in that 3 weeks to term, then on the percentage on their due date, a percentage afterwards where something will happen that will prompt the onset of labour. And that can be a mucousy show, what we call the operculum plug. It could be you start contracting quickly or progressively, eventually into strong labour, or your waters can break either as a more traditional, what we see on the movies, the big gush and the taxi, or just sort of a little bit of light loss. Sometimes you can have a build-up of secretions in pregnancy, what we call leukorrhea, that's the fancy name, and particularly overnight. You might get up in the morning and all of a sudden you sort of just wet your underwear, or a little bit of water goes down your leg as you're in the bathroom and you think your waters are broken, but that could actually just be your secretions. Sometimes that can be pink if there's been a little bit of dilatation of the cervix. And again, more traditionally, the big gush. But I think in relation to the first part of the question was, if you think your waters might have broken, they'll either be obvious, or if they're not obvious and you wish to seek advice, you can speak to your care provider, doctor, midwife, and or come in, and there are very simple checks we can do. If you have a baby that has passed a bowel motion, meconium, so their first poop is called meconium, babies do that often because they can. Okay, it's just a response of their body, and they just release their bowel and it goes into the amniotic fluid and it gives it a meconium green colour. But we know statistically that a percentage of those babies above and beyond, if the fluid is clear, can sometimes be, if we use the word stressed or distressed. Okay, so either stressed by something in the environment or distressed as in some sort of issue with their blood pressure or oxygenation. And so invariably when we see that, we would like to just check to make sure that the baby's heart rate pattern, in particular we do a CTG for most women in the delivery suites, is indicative of a baby that appears to be getting enough oxygen. Because that's the thing that worries us the most as birth providers, care providers, is the risk that a baby would suffer oxygen deficit, which is significant in terms of immediate and long-term consequence. So if you saw meconium, you would want to get that checked. You don't need an ambulance, but you just would want to come in and get checked. Blood-stained fluid, depending on the brevity of the amount of blood that you're experiencing, which dare I say will usually be light, is probably just reflecting the fact that if water's coming out, well, the cervix has to be a bit open, and if the cervix is a bit open, it's tissue stretching, and tissue that stretches bleeds. So it's probably okay, but again, if you're not sure, or there are other mitigating factors, symptoms, etc., call and or come in.
Pete, are there any other things that you want pregnant women to know about in their pregnancy care journey, or other things and other symptoms that they should seek help for? Yeah,
look, there are just so many symptoms that you can experience which are usually going to be normal. Normal for pregnancy. Headaches are usually not preeclamptic severe hypertensive headaches or a rupturing aneurysm or a brain tumour. Headaches in pregnancy are very common and are probably just due to the congestive changes of pregnancy or changes in your neck muscle supports and ligaments and so on, and you're getting referred pain. That's more common. Blurred vision. People sometimes find they change the refraction of their prescription in their glasses because they get a bit of fluid retention in their eyes, in the lens of their eye, so they blurred vision. Blurred vision is very rarely going to be dangerous and indicative of some other significant neurological problem. Chest pain very commonly is going to be reflux heartburn or esophageal spasm, as distinct from a dreaded pulmonary embolus blood clot or a heart attack, which is even rarer again. Pain, as I said, the vast majority of the time will be musculoskeletal. Discharge, clear or yellow discharge, almost always is just going to be just the vaginal secretions due to the hormone stimulation of pregnancy. People often will get tummy pains and you ask them the question, they say, I haven't used my bowels for 3 or 4 days because constipation is very common. Well, if you're loaded up for 3 or 4 days, that's going to be a problem. Urinating a lot during the day and at night, and sometimes with discomfort, is often not a UTI, a urinary infection. It's just there's a baby pressing on your bladder. I alluded earlier, 95% of you will get fluid retention in pregnancy, changes in protein and blood vascular system. Only 7% of you will get hypertensive preeclampsia. So the vast majority of you are not going to have high blood pressure to cause your swelling. But as much as we know that you're probably going to be okay, we don't know for sure. So I think the take-home message is that we would rather you come in for a visit you don't have than not come in for a visit you should have had. Okay, and so just err on the side of caution if you feel you need to.
Well, Pete, that was fantastic. Thanks for talking to us about red flags in pregnancy.
A huge thanks to Mistela for sponsoring this episode. Did you know that children of parents with a history of eczema, allergies or asthma have a high likelihood of having eczema-prone skin as well? Mistela's Stellatopia range is specifically formulated for eczema-prone skin. Fragrance-free, it soothes, protects and strengthens the skin barrier. Stellatopia products from Mistela go through 450 tests and measures to ensure safety and efficacy, and they are dermatologist and paediatrician tested. Mistela is our family's favourite.
You've been listening to the Expert Guide to Parenthood podcast. And never forget, parents, you've got this.
Join a Parents You've Got This masterclass today to be prepared, excited and educated for pregnancy, birth, baby and parenthood. Visit www.parentsyou'vegotthis.com.au and sign up for a masterclass today.
The information provided in this podcast is general in nature and is intended to support, not replace, a discussion with your doctor or healthcare professional. Parents You've Got This take no responsibility for any medical decisions made by individuals based on the information provided in this podcast.